Okay, welcome everyone. Good afternoon. Thank you for joining us today. My name is Pei Kai Shen, the Head of Program from Department of Psychology and Counseling, Faculty of Arts and Social Science, University of Dr. Rahman. I'll be moderating today's webinar entitled Treatment Options for Dementia by Professor Dr. Esther uh, Ebenezer. So Cognitive Health Series is jointly organized by Malaysia Mental Literacy Movement in collaborations with the Department of Psychology and Counseling, University of Dr. Rahman. Let me briefly introduce Professor Esther. Professor Esther is the professor in psychiatry at Uni KL Royal College of Medicine, Perak. She obtained her Master of Psychological Medicines from University of Malaya and Fellow in Old Age Psychiatry from the Universities of Western Australia, Perth. She has been the chairperson for the Dementia Society Perak since 2010 and has started the Dementia Support Group in Ipoh in 2006. She started the first Dementia Daycare Center in Ipoh in 2012 and proceeded to establish Malaysia's first purpose-built BBLEC Daycare Center for people with dementia. She is well known for her work on dementia in developing Ipoh model of care for dementia, which also includes plan to set up dementia-specific residential care. She is an EXCO member of the Alzheimer's Disease Foundation Malaysia. She had been an invited speaker for many occasions nationwide and in overseas conferences. She is actively involved as principal investigator in a lot of research and clinical trials with new drugs for the treatments of Alzheimer's disease and other psychiatric disorders. If you have any question, please type them in the chat box in your Zoom control panel. I'll bring them up during the Q&A sessions at the end of this webinar. To all UTA students and staff, kindly sign in your attendance in the link posted in the chat box. Now, without further delay, let's hand over the time over to Professor Esther. Prof, the floor is yours.
Okay, thank you, Mr. Kai Chai-sun, for inviting, and thank you for Utah students to organize this meaningful event to educate the people about the mental health issues, that is especially among the elderly population. Dementia is one of the most common mental health problem among the older people. So it will be good that if you can have some ideas on how to treat. Before I do this, I understand Mr. Pei must have spoken to you something about non-pharmacological intervention for people with dementia. So I'm glad to talk about the pharmacological intervention as well as some a little bit I'll talk on the non-pharmacological because it's very important to complement one another, not just only pharmacological management. Before I go further, probably I would like to take you down through the slides. Okay, so all of us, we know that dementia is not a part of normal aging. Dementia causes loss of memory, and normal people, elderly people also can have memory issues, but it is not consistent that every single day they experience that. But people with memory problem or something much more serious, they continue to experience memory loss consistently almost every day in every activities of their daily living. That will affect the quality of life and affect their functioning level and also affect the dependence. They become more and more dependent on others. So it also affects the thinking, the speaking, the right word won't come out, and they'll find very difficult to make decisions. Okay, so it is estimated that 5% of the Malaysian population above 65 years old are suffering from dementia. As our life expectancy is increased every year, our life expectancy is increasing. The longer we live, the higher chance of us getting the disease. So I'm just give you a little statistics about our Malaysian cohort who are 60 years and above. We have 3 categories: young, old, that is blue color, middle old is a red color, and the old is green color, that is 60 years and above. Now 2020s, we have very small proportion of people with 80 years and above, that's old, and a lot more young old we have. just in a matter of 20 years' time, it will fly very fast. We can see more old and middle old, and the young old is becoming less and less. Eventually, our country is already aging fast. So we need to be prepared for all the problems that comes along with aging. And one of the problem is dementia. Okay, I'll show you a video which gives you a lot of information within 3 minutes. Yeah. Okay, I hope you can listen
What
this.
is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your
Okay, so I think this is a very useful slide or useful video, gives you a lot of information about what is Alzheimer's disease. Yeah. So the treatment of Alzheimer's disease is 2 component. One is a cognitive aspect, another one is a non-cognitive aspect. So in dementia, cognitive aspect is the memory, having executive functioning, carrying out day-to-day activities. Non-cognitive problem is behavioral and psychological symptoms of dementia, where they will develop lots of behavioral issues like screaming, yelling, shouting, seeing things that other people don't see, that's hallucinating, having some form of delusions, believing that something that is not true. And it becomes very stressful for the caregivers. So when we talk about dementia, it's not just treating the memory problem. Yes, of course, at the early stage, but as the disease progresses, they will develop a lot of behavioral issues that also we have to address. On top of it, we also address the caregivers who are equally important and they need attention too, because they are the vital people who are taking care of the people with dementia day in and day out. So they also need help. So we need to address all these issues around dementia. So it is a holistic way of managing. Okay, so as in the slide that you saw, there are three consistent pathologies or neuropathologies that is how happening. One is called amyloid plaques, another one is neurofibrillary tangles, another one is neuronal degeneration. All together happens, and slowly the brain cells die, then the clinical symptoms start to appear. Yeah. At this moment, there is no medication available to stop this pathology that is happening or the progression of the pathology. Okay, so to make it easy for you to understand, there are two pathologies that is happening. One is outside the neuron. If you can see, this is the healthy neuron. In our brain, we have trillions and trillions of this single unit. This single unit is called a neuron. So this neuron has a cell body, dendrites, and then they have a long tail that is called the axons. Yeah, this cell body. So what number one pathology? Amyloid plaques. They deposit outside the neurons. These are not water soluble, so the proteins, amyloid plaque proteins, cannot go out from the brain through the blood-brain barrier. I hope you all read about blood-brain barrier. It cannot pass through the blood-brain barrier. So eventually it gets deposited outside the neuron, and it will start to kill the healthy neurons. That is the pathology happening outside the neuron. There's another pathology happening, neurofibrillary tangle, that happens within the neuron. So example, this is a head of the neuron. From there, the dendrites are there. Maybe this is an axon, a part of the tentacles or the hands or the dendrites. So inside that, the microtubules are placed in a right position without clumping together, without joining with another microtubules. These are held in right position by the tau proteins. It's called tau molecules. It's just like a bridge. When a bridge is built, they are kept in a right position by using bolts and nuts. Similarly, the microtubules are kept in a right position by these tau proteins. When the disease happens, this tau protein disintegrates. And then what happened? All the microtubules inside the dendrites and the axons will collapse. So imagine a bridge collapses, what happens? So all collapses, then the nerve from inside start to degenerate from inside, start to shrink, and also it will become fibrous, just like a clump of fibers. So along with that, the neuronal death. You can imagine this is the healthy neuron, this is the neuronal head body, and then long axons, and then dendrites. This also will become diseased and become smaller in size. So these are the pathology that is happening in the brain of Alzheimer's patient. So because of that, you can see the difference between the Alzheimer's patient's brain, mild Alzheimer's and severe Alzheimer's. You can see the ventricles have become big because the brain has shrunk, and then you can see the gray matter, the sulcus all become deepened. So this is how the pathology will happen when we see a cross section of the brain. Okay, so the main pathology is the two pathology, neurofibrillary tangles, tau protein, and the amyloid plaque deposition, A beta protein pathology. These two main pathologies needs to be stopped in order to prevent the progression of the disease. But until today, there is no medication available for use. Recently, some vaccine came, aducanumab, but it was approved by the FDA, Food Drug Administration, yet there were many controversies, so it is not available for use yet. Okay. European Federation of Neurological Science Society recommended cholinesterase inhibitors and memantine alone. So how this cholinesterase inhibitor is going to work on Alzheimer's patient, I will let you know, and how the memantine is going to work. So memantine alone or in combination with cholinesterase inhibitors we can prescribe. Usually in mild or early dementia, we normally give cholinesterase inhibitors like rivastigmine, donepezil, galantamine. As the disease progresses, we might add on memantine. Why? Later memantine, because when the disease progresses, that part of the pathology that happens is only at the later part of the disease. That is why memantine is useful for later part of the disease. There is not sufficient evidences for the use of ginkgo, anti-inflammatory drug, neurotropics, salicylic, estrogen, and other vitamins. Yeah, so it is not the mode of treatment. Okay, so the medications prescribed, as I told you, mild to moderate dementia is cholinesterase inhibitors. And if it is vascular dementia that is due to stroke patient having mini stroke or recurrent white matter changes happening, that means there is clot in the blood vessels that occlude the blood supply for a deeper part of the brain over a long period of time, they can cause vascular dementia. Parkinson's disease dementia, usually reverse treatment is indicated. As the disease progresses from mild to moderate to severe, then we use memantine alone or in combination with cholinesterase inhibitors. We need to know about the side effects that comes along with the drug, like vomiting, nausea, giddiness, headache, body ache, and then they can have reduced appetite, weight loss. So all the medication have their own side effect profile. We need to understand any medication before we prescribe. Okay, so what is the importance of early treatment? The early we treat, you can see they can have a better quality of life for a longer period of time. So that is why it is so important that we embark in early diagnosis, public awareness. Maybe I can share with you all my very simple public awareness book that we did publish. It is available in the soft copy. I share with Mr. Pei, probably you can share with your students. This is for public education so that they come and get help as early as possible so that our people with dementia can have a better quality of life or independent living for a longer period of time. What happens if we start the medication later part, as after the disease progress over the time? Then the time limited is so little. Even with treatment, the outcome is not going to be that good. So that is why we need early diagnosis and early treatment. So these are the drugs now available in all over the world. Only these 3 type of medication is available, and it's also available in Malaysia. Popularly, number 1 and 2, galantamine is not so common, but in Singapore it is quite widely used. It's all the same mechanism of action. What happens? This is, imagine one neuron, the nerve cell that I told you, we have trillions and trillions of neurons. One end of the neuron, this end will get connected to another neuron. So in between one neuron and another neuron, that's a space called synaptic cleft. So what happens in the normal situation, the acetyl coenzyme and choline together will form acetylcholine. And acetylcholine is the important neurotransmitter that is for memory. God has created us in a very, very special way. We have hundreds of neurotransmitters in the brain, and each of the neurotransmitter have its own function. So one for that is acetylcholine, that is very important for memory. So this medication, what it does, okay, in general, acetylcholine will come from the presynaptic terminal and goes to the synapse, and it goes to the postsynaptic terminal through the receptors. So from here, from presynaptic terminal, it comes to the gap, and from the gap it goes to the another neuron. So in such a way, all the information that is given, like you're listening to me, to my talk, you listen and it absorb and you keep. All these things you imagine in your brain, this activity is going on. Acetylcholine is secreted more because you're focusing more, and then it will go to the next neuron, and it will pass information and it absorbs information. That's what continuously it happens in the brain. Yeah. So when this acetylcholine comes into the synaptic cleft, there are enzymes called acetylcholine esterase. What is acetylcholine esterase? This is an enzyme. It will break down the acetylcholine, or it will destroy the acetylcholine. So the amount of acetylcholine becomes less, Imagine if this neuron is diseased, the amount of production of acetylcholine becomes less. If this postsynaptic neuron is diseased, the number of receptors to absorb the acetylcholine becomes less. In total, we will have reduced amount of acetylcholine activities. That means the production is less, the absorption is less, and the acetylcholine, whatever left behind in the cleft, is being destroyed by the acetylcholine esterase. So the drugs, nothing it does, it goes and blocks the acetylcholine esterase enzymes so that it don't destroy the amount of acetylcholine that is transmitted into the synaptic cleft. So the concentration of acetylcholine increases, and then it is transmitted to the postsynaptic, another neuron. So this is how the medicine works, but there is no medicine to stop the A beta protein production, and there is no medication to stop the disintegration of tau proteins. Yeah. Okay. So we have this medication called Aricept. We popularly use this, is the first one to come in the market. It is in 2020. Yeah. It came to the market here with us 20 over years. Next came the rivastigmine or Exelon patch. It came after donepezil a few years, 2-3 years later. And initially it was a capsule form, a lot of side effects like nausea, vomiting, diarrhea. So they came out with a patch formulation. It's a 5 patch, 10 patch, and 15 milligram patch. So we don't tell 13.5 milligram, we say a 15 patch. Yeah. So this patch we apply once a day. It will be there in the body for 24 hours, slowly release the medication. In that way, the medication is slowly delivered to the body over the period of 24 hours. Rather than you take the medicine, the concentration goes high, the person will develop nausea, vomiting. When concentration goes down, then you have to take the second dose in a day, because it has to take twice a day. Whereas the previous medication, Aricept, is only once a day. This is a once a day medication, but rivastigmine had twice a day. So they came out with this excellent idea of having this patch. Okay, so it can be applied. We cut here, open it. It's very simple, nice, round plaster. Nobody knows it is a medication like. It is quite nice. You can apply any part in the body as showed here in the figure. There should not be hair. Yeah. Okay, so apply once a day, more or less the same time, plus or minus 1 hour should be okay. So how the medicine works? It will get absorbed from the skin. It goes into the subcutaneous tissue. You know, our blood, our skin is a lot of blood vessels there, and this blood vessel will absorb the medicine. It will be directly going into the blood. So in this way, we bypass the medicine going into the stomach, irritating the stomach, and getting absorbed from the intestines. So it is easily absorbed, and it gives a smooth delivery of medicine. So these two medications are available in our country. Okay, the other medicine that is available is memantine. It is otherwise called N-methyl D-aspartate antagonist. It blocks some chemical action in the brain. Okay, maybe I give you a simple example. This medicine, I'm not going to go into very details. What happens, the memantine goes and blocks the glutaminergic receptors in the brain cell. In a diseased brain cell, the noise is so high within each neuron. Remember, imagine this one neuron, the trillions of trillions, one among the neuron is this. If it is diseased, the noise within the neuron, the background noise is very high because it's toxically tensed. Yeah? Imagine if you are in your classroom, then left and right classes, they are making lots of noise. When your lecturer is teaching, you wouldn't be able to absorb that well. But if your place is quiet, and you can absorb better. Similarly, this drug goes and blocks the glutamine, and it reduces the noise within the neuron. So the noise within the neuron becomes less, and the absorption of the information is better. Yeah, this is how the medication works. This is how these are the two medications that's available. Okay, Apart from this, what has been found? This is a very important and interesting research did in the European country. It is called a finger trial. Finger trial, what it says, it's not just the medication, the healthy lifestyle also important. Even after the diagnosis, you shouldn't stop your healthy lifestyle. Okay, what happened in the finger? This is called a finger research. It's a multi-domain intervention of diet, exercise, cognitive training, monitoring the vascular risk factors, and controlling. They did few countries in Europe. Is a prospective study for 2 years. What they did, they collected people, older people. One group they gave intensive multi-domain intervention. Another group they just regular health advice. That's all, nothing much they did. All these people are people with mild dementias, and one group given nutritional support, what are the how to eat, all very intensive training, exercise twice a week, and increase the exercise regime, aerobics, muscle strengthening, all these exercise they went through. Apart from that, they also had cognitive training. Again, they monitored the vascular risk factors like hypertension, diabetes, cholesterol, make sure it's well controlled. So all this one group of people, and they compared with another group of people which has nothing much intervention. So what happened over the 20 years, 2 years time, those people who have given intervention, they did very much better, significantly better in executive functioning, processing speed, and also with the memory. So what it tells us, it's not just taking Aricept, Exelon, or Memantine. Apart from that, the other interventions, the cognitive interventions, the proper control of the vascular risk factors, proper diet, exercising, socializing, all this also important to reduce the rate of decline of dementia. Okay, so this is the cognitive aspect of dementia treatment. Now we go to the non-cognitive. Non-cognitive, generally we call as BPSD. I think you might come across this term, BPSD. BPSD means behavioral and psychological symptoms of dementia. Okay, so mild behavioral and psychological problems. The first line of treatment is non-pharmacological. Really not necessary to give any medication for mild BPSD symptoms. But if it becomes moderate to severe, we can add on medication along with non-pharmacological intervention. Medication should be given only when necessary basis, not on regular long-term use, because if this medication used long-term, they have more complications like having stroke and increased mortality. They die much earlier compared to those people who are not given this antipsychotic medications. So there is a black box warning from the FDA, Food Drug Administration, not to use antipsychotic agents for a longer period of time. Okay, so what are the symptoms? They can have psychotic symptoms like hallucinations, delusions, misidentifications. They can have affective symptoms like depression, anxiety, apathy, disinhibition, elation. Other behavioral symptoms like aberrant motor behavior. What is aberrant motor behavior? They just walk around up and down for no proper reason. Maybe they wanted to have a cup of water. They go to the kitchen to have a cup of water. By the time they reach kitchen, they've forgotten for what they wanted to go to kitchen. Say they don't know what, then they come back. So they keep up and down pacing. That's called aberrant motor behavior. Irritability, agitation, nighttime behavior. That means nighttime they wake up, ransack around, look for food, trying to get out from the house. So appetite changes, can be hypersexuality. A lot of behavioral and psychological symptoms can happen. Yeah. So I have many examples how our patients, family members do suffer. I remember one of my earliest patient, husband was having dementia. The wife was taking care. Suddenly, the husband thought the wife is a stranger in the house, and he see none of his sons were there because they are already grown up. They went to Singapore to live. And suddenly he thought, hey, she's an intruder. She has killed the children. Then he came to attack the wife, not knowing she is the wife. So she has to hide herself. Many times she would sleep inside her car. And the husband, once he doesn't see the wife, he will feel okay. He could not recognize the wife as a wife. He thinks that's an intruder. Yeah. So there are many behavioral problems can happen. Um, Medications alone not enough. Non-pharmacological also very important. As I told this lady, poor lady, she'll have a light, torchlight, she'll have a book, she'll have a mosquito spray, she said. Yeah, so that's how they lived. It can be very, very stressful to handle people with dementia. Yeah, and maybe I can give you another example, many example. That one, the wife having dementia, the she always keeps on the switch. Whenever she see anywhere, she'll on the light. That's her problem. The husband will go and off, and she will on. So that becomes a big confusion and conflict between the husband and wife. So when educated, this is not her doing, it's because her sickness she is behaving this way, then he accepted, but he was very, very innovative. I really liked him. He took a white paper, took a cellophane tape, and covered all the switches. So she couldn't see the switch, she won't on the light. So for this type of behavioral issues, we no need to give antipsychotic medications or whatever it is. Just the manipulation of the environment can do a lot of good things. Yeah. So there are many behavioral problems can be handled with non-pharmacological treatment. So we have to understand, even before the diagnosis of dementia is made at this line, they already start to show some emotional problem, depression, social withdrawal, some paranoia. Yeah. And after the diagnosis, they have lots of other symptoms like agitation, aggression, hallucination, delusion, irritability. So what I wanted to show in the slide, the BPST is so common among people with dementia, even before the diagnosis and also after the diagnosis. It is why, because there are lots of things happening. When they did the PET scan with the people with the BPST symptoms, they have seen agitated people have a lot of hypoperfusion in the frontotemporal. I think you all will know, right? Frontal part of the brain is this frontal part, and this is the temporal part of the brain. So this part of the brain, there is reduced amount of blood flow. That is what they found, those people having behavioral changes or agitations. And after the person died, then they did the section of the brain, and they compared those people with dementia without agitation and with agitation. And they have found those with agitation had lots of neurofibrillary tangles in the front part of the brain. You know, all of us, we know the front part of the brain is so important for us to, the brain will tell us this is right, this is wrong, you should behave this way, you shouldn't behave that way. That is how we are maintaining our higher functioning level. What are the things to do and things not to do? So again, social norms. So when this front part of the brain is affected, they will develop a lot of behavioral symptoms which they don't know that is not right. Yeah. So always we have to educate the family members not to put on the person individually. We put the blame on the disease that caused this behavioral symptoms. Okay. So, and again, as the disease progress, they don't understand much. When you talk with them, you have to talk with a short and simple sentence. The more you talk, the less they understand. So don't give lectures. Just give one or simple sentences. Use familiar words. Don't give choices. Oh, today breakfast we give bread and butter, or you want noodle. Don't give you choices, because they can't make choices. Yeah. If you want them to do work, have to break down into steps. Not okay, today go and have your shower. No, it's not going to help. You have to go step by step. Take the baju for them, take them to the bathroom, on the shower, tell them this is the soap. Maybe don't have soap and shower. They get confused. Maybe have one rather than two. Shampoo separately, body soap differently. So a lot of things we have to do. Then don't give open-ended questions. I think we all know open-ended questions. they wouldn't able to understand. And always remember of body language. Often our body language speaks louder than real words. I think in your classes also you must be reading about the body language. Yeah, they can understand a lot from the body language, even though you think they are demented. And when you're talking with them, we have to go to the same level, eye to eye level. When they are sitting, you can't be standing and talking to them. You have to sit to their level so that the eye contact is maintained. They understand you better. Give them a hug. They will understand. They will feel a lot comforted. And don't talk to them from the back. You have to talk from the front. Don't touch them from the back. They become startled. They become scared. So always have to be very careful with the simple things that can avoid lots of behavioral problems. Yeah. So here I'm going to show you a video, a simple video. It gives you a lot of information. The person in the first video, she's so focused on her work, she neglected the person's need, and you can see the outcome.
Where are my slippers? I say, where are my slippers?
They're on your feet.
No, Mrs. James has stolen them.
Mrs. James is dead.
No, she's not. She's stolen my slippers. Oh, Tony, she took them.
So you can see here, she's so busy attending to her cleaning, didn't bother to attend to this person's need. She is wearing the slippers, but she's just go and rationalize with her. Don't rationalize. The more you want try to teach, nothing will go in. Just go along with the flow. If they say A, you also have to say A. If they say B, you also have to say B. So if she says somebody stolen, it's okay. We will see to it. Okay, maybe here I show you the other video.
Where are my slippers? I say, where are my slippers?
Mary, you're wearing them.
No. Mrs. James has stolen them.
Should we go to your room and have a look for them?
Oh, all right.
So you can see the same scenario. The same thing can handle in a right way, in a better way. Yeah. When she says Mrs. James has stolen, she acknowledges. Okay. And then she says, let's go and check for it. Yeah. So the end product is a lot better. That is why always we employ the terminology A, B, C of behavioral therapy. A is the antecedent. What happened? That is, she was talking about the thing somebody is stolen. And what's the behavior? If you are not attending to that, she is going to be agitated, and the consequences, end up with more trauma rather than having a pleasant ending. So we always have to look for A, B, C. Any triggering factor, what is the behavior associated with that, what are the consequences, how to handle it in a better way. Okay, so what are the medications for BPSD symptoms, behavioral and psychological symptoms? The cholinesterase inhibitors that I mentioned to you also can help. It is not only for improving the memory, it also will improve the behavioral symptoms. It also will improve their functioning levels. So cholinesterase inhibitors are helpful. Apart from that, you see, it helps in agitation, aggression, depression, apathy, delusions. All it helps. And if you see the behavioral intervention, it can also help quite a lot of the domains. Whereas if you can see antipsychotics, it can help only the agitation, aggression, and delusion, hallucination. Antidepressants can help only the depression and apathy. Anticonvulsant, not commonly using, but it still can use for some agitation. Benzodiazepines have little role. Yeah, so we need to combine cholinesterase inhibitors and behavioral intervention. We can manage better rather than resorting to antipsychotic drugs. So antipsychotic drugs can be used to treat the BPSD symptoms, like I mentioned to you before, but always remember non-drug therapy should be used before using antipsychotic. So usage is only appropriate when necessary in a severe case, when together with the non-pharmacological management. This is the recommendation by NICE guideline. What is NICE? NICE is Institute of Clinical Excellence. Yeah. So National Institute of Clinical Excellence. This is UK guidelines. They recommend only when necessary basis. These are the antipsychotics that we can use. Maybe some of you could have heard: risperidone, olanzapine, quetiapine, and many more. But if you use on regular long term, it can cause cardiovascular accidents and death. Okay, so along with antipsychotics, we have to know lots of side effects. Anticholinergic side effects, extrapyramidal, anticholinergic dryness of mouth, extrapyramidal means we can have shaking and tremors, tardive dyskinesia also can be weight gain, diabetes, some blood problems, prolactin elevated, a lot of falls, sedations, a lot of side effects are there. So that is why we need to use only sparingly when absolutely needed. Okay, antidepressant, we have quite a number: escitalopram, sertraline, this is Lexapro, Zoloft, paroxetine, Seroquel, fluoxamine, or Prozac. They can be used when the person you suspect having depression. Always first line medications are this medication called selective serotonin reuptake inhibitors. Next, we can also use carbamazepine or sodium valproate. It is not commonly used. I'm not going to talk about it much. And benzodiazepine, like short acting. Don't give long acting like diazepam. It's a very long acting. Once in the body, it will take long time to get out from the body. Short acting like alprazolam or lorazepam can use, but they have to use very low dose and look for the side effects, because lots of side effects comes along with benzodiazepines, like falls, confusion, sedations. So we have to be very careful. Again, in gold standard in older age group, whenever we start any medication, start low, go slow, because the absorption is slow, the metabolism is slow, the excretion is slow. So we have to start at the lower dose. Slowly we increase the dose to the optimum level. Yeah. Okay. So benzodiazepine should be avoided as much as possible. If at all we are using, you have to use with great caution. Okay, and long acting like benzodiazepines cannot be used. The caregivers, importantly, a person is experiencing dementia, they have lots of cognitive problem where the activities, daily living will be affected. A person need to attend to the activities of daily living, the memory issues, and also behavioral issues. It causes a lot of stress among the caregivers. So the caregivers are the backbone in managing patients with dementia. So those people should not be neglected. They should be given enough training, enough support, so that they can able to handle their loved one as caregivers. Very often they care alone 24 hours, 7 days a week, no social contacts. They get very burnt out, they get exhausted, so they need support. So we do have support group in Perak, the Dementia Society Perak, and also nationwide we have Alzheimer's Disease Foundation Malaysia. They are very good. Jenny, she always organizes every weekend. There will be something to educate the caregivers. She'll get into all the speakers around Malaysia and overseas. She'll get somebody to talk. Usually on weekends, she will organize some talk, always on the Zoom. She's the expert in Zoom. Yeah. So she's 75 years old, I think, 75 or 76 years old. She's doing an excellent job. This support group is important, where they can share their knowledge, their pains, their sufferings. One caregiver share the information with the other caregiver, how they manage some difficult issues, difficult problem. Then it will be easier. This is the Alzheimer's Disease Foundation. Maybe you can have this for any support, future support. And as the disease progresses, when the caregivers really get burnt out, we can give them other support. One is training caregivers how to cope with the difficult behavior. One. Number two is having support groups to support together. Number three, we should have some social service system available at the community level. So one among it is the Dementia Daycare Center, where they can leave their elderly loved ones in the morning and take back in the evening. Just as we send our kids to kindergarten or play school, our elderly with dementia can come to our day center as a play school and go back in the evening, so that the children, the caregiver can go and work and earn a living. So in early dementia, it is helpful so that they have social interaction. The rate of decline will become less because they constantly get stimulated. In the middle stage, when they develop behavioral problem, when the caregivers find very difficult to cope, then they need to have daycare centers will help, so that the caregivers have a break. They get recharged. It's for respite for the caregivers. Yeah. So I'll show you a video of our daycare center.
If you don't care about them, if you don't listen to their talk, they will feel very belittled. So we need to talk to them. They can tell 10 times the same story, nothing wrong in listening, as if you are listening for the first time. As the disease progresses, slowly the basic activities of daily living will be affected. For example, like bathing, they go inside, don't know what to do, they come out without having shower. Will have a lot of trouble with remembering, so it is difficult for them.
Hallucination, sometimes they will tell you, got people there telling me to do this and things like that.
So as the disease progresses over the years towards the terminal stage, you need to really take care then of a real baby. Yeah, that stage will come. It is not so fast. It will take years. It will take years. So you need to be prepared for it.
We really have to be patient, or else we'll jump into her, because very frequent almost that she's forgetful, and then she will always throw a tantrum. The tendency of throwing a tantrum is very frequent.
Along the way, when the person is declining from mild stage to moderate stage to severe stage, along the way they will develop some behavioral issues where they will start screaming, yelling, shouting, shadowing. Shadowing means when the caregiver goes anywhere, the patient will follow. Just like a little kid following the mother wherever mom goes. So these are the things that can happen. That can be a lot stressful for the caregivers. In the BB-like center, we have a lot of facilities for old people. One of the important things, they have to look prim and good. They should feel very happy about themselves. So we often, once a month, Madam Wong will come to cut hair for our patients. It is important when people with dementia, they should come here to the places like day centers like this, because it is important. It will delay the progression. We have specific activities. For mild dementia, we have specific activity. For moderate dementia, we have specific activities. So this, even for severe dementias also, we have some activities for them. So it covers the whole range of mild, moderate, severe dementia. So when they do come here at the early stage, they can get used to the place here. They get socially connected with other people. They keep their mind active throughout the day. We don't allow them to sleep. From the morning they come until the time they go, they are doing some activities. So usually in the morning we start with morning exercise in the sunlight to get some vitamin D. Later they'll come in and do indoor activities, some games. Then they will have singing song session together where we mix the mild, moderate, severe together at one go. And then we will separate them into different activities. This room is for people with severe dementia, where they are not able to do a highly challenging activities. So they are given activities according to what they can do. So this is beading. Beading is one of the interesting activity they do. It's not just the bingo and the beading. We have many other activities. We will do it at regular intervals. This activity room is for mild dementia, where people with mild dementia can do cognitively more challenging activities. Bingo games is one of the games they really love to do that.
If I don't send him to the center, I keep him in the house. He's alone in the house, just the two of us. No activities, Whereas here, he's mingling around with so many people. and the physical activity, exercises, and then the mental stimulation, it all does a lot of good for him.
Since we don't allow them to sleep here, throughout the day occupied, when they go back home, they can sleep well.
So
If you
they do the beading, they can wear the beads. We do have a nice garden along in the morning.
Dementia-friendly therapeutic garden is first of its kind in Malaysia, which is sponsored by Rotary Foundation Global Grant initiated by the Rotary Club of Greentown in the year 2018. The garden is designed to cater for both the physical and mental stimulation for individuals at each stage of the disease. The garden provides physical exercise, restores calm and tranquility, triggers happy memories of their past, and minimizes agitation. The design of the garden invokes and stimulates the five senses of sight, smell, hearing, taste, and touch when one walks around the garden. The walking pathways are circular with no dead end to reduce confusion. Bright yellow color handrails are fixed throughout the walkway for safety purpose, with garden chairs for clients to rest. Hanging garden with fragrant flowers and creepers provide a unique experience for the clients as they walk through it. Bamboo Grove provides a visual greenery, and the rustling sound of swaying bamboo leaves stimulates sound senses. The water features like the fountain and dolphin sculpture are attractive, and the sound of running water serves to distract agitated clients. Potting beds offers unique opportunity for wheelchair and walking clients to participate in potting and planting flowers or vegetables. This helps to improve body movement and retain muscle strength. Fruit trees are planted to stimulate their memories and to improve the orientation to fruit seasons. Spices patches stimulate sense of smell and touch. Koi pond with running water and fishes swimming generates calmness yet excites the individual to see life in a pond, to bond oneself with nature. This creates a peaceful, serene experience.
Okay, so that's how it is. This is in demand in Ipoh. I know there's quite a number of students from Utah come and do attachment at our place. You're welcome to do your internship or your training after your attachment with us. Yeah. Okay. In conclusion, the medications are available to use. One is for memory, another medications are to control the behavioral symptoms. These medications are not a cure, it is just a temporary fixing only. If it is a behavioral issues, always we go for non-pharmacological treatment first before resorting any medication. Always we have to be aware of the side effects that comes along with the drugs. So most importantly, the caregivers need equal attention because they are the backbone of caregiving. It is easy to care for a small little child born, newborn, or a 2-year or 3-year-old kid, but it's very difficult to care for an elderly who behaves or who need attention just like a 2-year-old kid. Yeah, it is going to be very difficult. So caregivers are equally important. We need to attend to their needs also. With that, I would like to say thank you, and I wish to take any questions. Okay, we have 5 minutes.
Thank you so much, Prof. So we will take some time for questions now. Just a reminder, please be sure you to type your question in the chat box.
Maybe if you could read out for me, it will be easier for me.
Yeah, sure. If there's any question. So we have someone sharing that my friend's husband said that his wife is his mother and his son is his brother. His wife was a nursing sister but unable to handle her dementia husband. She had to send her husband to a nursing home to bathe and clean. Yeah, I understand this is not easy. Prof, do you have any comments on such a situations?
Yes, the stage will come. Definitely, a stage will come. Is it is? I think if you go and read about Prof. Riesberg, he spoken or he has done a lot of research about retrogenesis. What is retrogenesis? It's a second childhood, where the elderly person goes backward to the stage. They come to the newborn stage. What happens in a newborn baby? We have to change the nappy. We have to mandi the baby. We have to feed the baby. We have to take care of the baby. Like that, a stage will come. So it is a very big baby. How the person is going to handle it is going to be very difficult. So you need a lot of social support system. Maybe some help. Maybe paid caregivers who can come and give regular shower. Not necessarily every single day the person should shower. Maybe one alternate days they shower. So shower becomes a big problem. They don't want shower, leave them alone. Don't need to force them at particular time in the morning you have to shower. Maybe in the afternoon they feel comfortable, let it be. When they shower, don't straight away start shower from the head. You should start from the leg, wet the body, and finally come to the head, because straight away water on the head will be a bit shocking for them. So all these things we have to tackle, and an elderly wife taking care of the elderly husband is going to be a lot difficult. Many elderly people, they have strained their back just because of direct caregiving. So they have to take care of their own health. So if they need help, they have to open the mouth and ask for help. Ask, ye shall be given. People might not really know your requirement, your wanting, what are the things that you need, the help. Maybe you need to share with the children, with your relatives, I really need help. So there are some good souls, they can come and help. If not, you have to get a paid caregiver. If really cannot handle at all, then nursing home could be the last choice, because in nursing home the care is not going to be as good. Yeah, as you all know, many of us will know, nursing home, makan tidur, that's all they feel. They wake them up around 4 a.m., give them shower, breakfast early in the morning, they go to sleep by 6 p.m. Yeah, 6 p.m. is still very early for us. They will start going to bed by 6. So nothing much. They will fast deteriorate in the nursing home. But if there is no choice, I'm not sure we have to discuss with the family. It's a family issue. It's not an individual person's issue. It's a family issue. We have to work together, have to share the burden together with other family members.
Yeah, that's right. We have Lo that raising up his hand here. Do you want to open your mic to speak? Lo? Okay, probably not. We have another questions here. Is dementia heritable?
So dementia,
Is dementia heritable? Genetically
heritable,
heritable?
inherited. If it is early onset dementia, if the person gets before 50, before 60 years or early 60s, is considered early dementia. If it is early dementia, there are some chances your other people can get. And if you have a family history of dementia, if your mother or your sisters or anybody in the family had dementia, that is early onset dementia, you also having early onset dementia, then it tends to run in the family. It is often uh, thought it's due to the gene called APOE4, that is apolipoprotein E4 gene. This is one of the bad gene. If you have two genes also the same, APOE4, you have a higher chance of getting the disease. Yeah, that doesn't mean you have to go for a genetic test. That doesn't mean 100% you're going to get the disease, but a little bit extra chance, extra risk compared to the general population. Maybe another 10% risk, 90% risk you might not get. So why should you start worry about that 10%? Yeah. Even though you have the 10% chance of getting, having a healthy lifestyle that I told, having socially connected, physically active, make sure you eat well. If you have hypertension, diabetes, you control well. After retirement, not makan tidur. You socially very busy, make yourself active, enjoy your life rather than looking down at your aging process or retirement process. It is also a protective factor. What is the latest finding? Is the loneliness is one of the risk factor for dementia. So don't stay alone, do nothing. Even though you're alone, your children all terbang already at home. After retirement, look for things to do. A lot of things are available you can do around. It's just you have to open and look. You have a lot of things can be done at the place where you live. Yeah.
We have two questions that is related over here. One question is what are the side effects of Exelon patch? Number two, have family members or the patients would stop medications due to side effects?
Okay, yes. As I told you, all the medication comes with side effects. There's no medicine without side effects. Yeah, all has its own side effects. Exelon, you can have nausea, vomiting, reduced appetite, giddiness. It can happen. If it is not tolerable, you need to talk with the doctor and see what can be done. So that is why we go down titration, very, very slow titration. The first month when we start the medication, we start only with the 5 milligram. If the person is doing well, no issues, then the second month we go to 10 milligram patch. And then we keep it 10 milligram patch as long as the patient can tolerate the medication. And if we don't increase to 15 patch straight away, because the optimum dose is 10 patch. 10 patches, 10 milligram patch is sufficient. And along the way, when the person deteriorates fast, when the person goes down fast, then we increase the patch from 10 to 15. So we straight away from 5 patch, straight away we don't go to 15. Always titrate, slow titration up will reduce the side effects, number one. Another problem with Exelon patch, I didn't show you, they can have patch, can cause some skin irritation. Yeah, they can show some skin irritation. If it is just the redness, you no need to worry about it, because redness is not an issue. Maybe I show you the picture. I just because I thought it would be time consuming, I took it off. Okay. So like, okay, it's just the redness. Okay, I show you here. Can you all see? So most often 80% of the people do have this redness. It's nothing to worry about. That is why you can't apply the patch on the same spot again and again. You have to change to different location that I showed you in the picture. So this is nothing to worry. But if the skin reaction comes out like this, swollen, itchiness, then you cannot use this patch. So you need to discontinue, you have to take oral medication. Yeah. So all the medicines definitely got side effects. So we go very slowly. If they can't tolerate, we reduce. Sometimes we see Exelon cannot tolerate, we go to Aricept. If Aricept also cannot tolerate, then we start the Memetin. Rather than starting late, we can start early also can. Usually Memetin not much side effect compared to cholinesterase inhibitors. Okay.
Okay, thank you very much. We have a couple more questions here, but we are running out of time. I guess those people who may need have further inquiries, they can either visit Professor at the clinics or email Professors. Do you take email?
Sure, can.
Yeah. Okay, so probably we'll share the email later on with participants. And all right, so thank you very much for joining us for today's sessions. Prof, do you have any last words for the participants?
I think it's good. People take part. Probably early diagnosis is important. If any one of your family or friends having some symptoms, please don't ignore. Come and check with the doctor for early diagnosis. Maybe I share with you the public education book. Now I'll share with you. Probably you can share with other people. It will be useful. It is copyright. If you wanted to print, also can. If you have no problem, we have no problem with that. We want it to reach to as many people as possible so that they can get benefited. The community get benefited.